Financial disclosures, patient surgical failure on various hospital and massive surveillance which patient and whatever investigate. We have no financial disclosures. Our patient, a 58-year-old male of Indian descent, presented to us with complaint of sudden onset painless diminution of vision in his right eye for over a month. His visual acuity representation was only perception of light with inaccurate projection of 3 points, and as per the view of the retina, formed an unsupervised with right eye. It was suggested vitreous hemorrhage with subretinal hemorrhage and nearly 360-degree hemorrhagic vertical detachments. And I will check now. Following placement of an AC maintainer, a single 23-gauge port was used to visualize the choroidal detachments internally, find out the left side of the image. A dark shoe can be seen under the retina, probably due to the subretinal healing. Drainage of the suprachoroidal space was first attempted in the infranasal quadrant using a 23-gauge port with external tamponade. However, it was unsuccessful at this time. The vitreous cavity was then accessed using a 6 mm infusion cannula. Vitrectomy was done to remove the vitreous hemorrhage. Retina as well as the choroid can be seen to be fairly flaccid at this time, probably because of the large amount of heme present in the suprachoroidal as well as the subretinal space. A posterior vitreous detachment was also induced to further mobilize the vitreous as well as the retina. Following completion of vitrectomy as far as possible, heavy perfluorocarbon liquid was now injected over the posterior pole to stabilize it and provide some internal tamponade. After having raised the infusion pressure to 16 a non-porous cannula was first charged to drain the suprachoroidal space. However, a CD spatula when inserted into the suprachoroidal plane left the pushing out of the heme, as we can see here. Following complete drainage, infusion pressure was returned back to 20 mm of Hg and vitrectomy continued. More perfluorocarbon liquid was inserted and peripheral retinotomies were made, this time to drain the subretinal heme. As we can see in this video now, the heme has started to drain, and with insertion of even more perfluorocarbon liquid, a gush of hemorrhage can be seen almost like an avalanche, even momentarily obscuring our view. After having cleared all the heme from the vitreous cavity, active suction was done using a soft flute needle from the peripheral retinotomies. EFCL was then removed from the posterior pole, followed by a fluid and exchange to flatten the retina. We had made a posterior retinotomy nasal to the optic nerve head, which was now used at this point to actively drain any subretinal heme which was remaining at the posterior pole. This was followed by multiple rows of laser around all the peripheral retinotomies, along with a 360-degree peripheral barrage. Any remaining heme from the posterior pole was further drained, followed by a laser around the posterior retinotomy as well. And silicone oil was injected into the vitreous cavity to achieve a well-laser attached retina post-operatively. The bones were sutured, and the patient presented to us post-operatively with a stable, best-corrected visual acuity of finger counting 2 meters, and we have a few pointers to take home from this surgery. Visualization of choroidal detachment could help in evaluation of the best site of drainage and may even facilitate live visualization. Placement of an AC maintainer and raising the infusion pressure of up to 60 mm Hg would further help to give us a good internal tamponade. Additionally, we can use a CD spatula as seen here to create a plane for drainage of the suprachoroidal plane. Use of PFCL can be extremely beneficial in draining out the subretinal hemorrhage, and also let's never hesitate to make a posterior retinotomy to remove any retinal blood at the posterior pole. But most importantly, in any such case, remember, patience is the key.
Thank you, Dr. Obuli.
Thank you.
What was the cause of the hemorrhage?
We are suspecting polypoidal choroidal vasculopathy. The other eye showed some changes of pachychoroid in the OCT of the posterior pole. So we are suspecting that because the patient came to us 2 weeks after that. So we, during surgery or post-surgery in the OCT, we could not make because the ISOS was completely damaged. So we are suspecting polypoidal choroidal. We did not do any angiography post-surgery. So, but this is what we are suspecting.
The other eye was fine?
Other eye was fine, 6 weeks. Yeah.
So why you didn't do the angiography? Because you want to save the other eye also.
Yes, ma'am.
So why?
So we are keeping the patient. The patient is from Kashmir, so he is not followed up after that. So we saw him 3 months post the surgery, and I had advised him that we might have to go for a follow-up angiography, but the patient hasn't followed up back to us.
It can be done in Kashmir.
Yes, ma'am. Yes.
You can tell him to do it there.
Yes, ma'am.
Anyway, so I also wanted to ask that in a case like this, would you like to start with systemic steroids first before doing the surgery? Because systemic steroids in these cases have shown dramatic reduction of that suprachoroidal hemorrhage, especially because this is sort of a idiopathic case.
Yes,
And otherwise also in most of the suprachoroidal hemorrhages, if we give steroids, then there's a time for the PVD to happen.
Yes, ma'am.
And for the suprachoroidal hemorrhage to reduce markedly.
Yes, ma'am. But the presenting intraocular pressure was very high, and he had come all the way from so he had a very short stay planned in Delhi for the surgery. So we had to take him up for surgery on day 3 after seeing the patient. So ideally, yes, ma'am, and a systemic steroid would have helped. Yes.
Yeah. Very well done surgery and very well managed. But I would actually expect the suprachoroidal hemorrhage to be, thick. And I was not expecting it to be so, fluid-like and to be drained, because from the ultrasonography, it looks still hyperechogenic.
Yeah.
So in those cases, we usually wait for it to liquefy a bit, but I'm surprised that it came out quite nicely, and also the subretinal blood too. So they were all liquefied. I don't know what was the
The patient's history of loss of vision was 2 weeks prior to when he presented. So by the time the clot may have liquefied enough for us to drain. Touch wood, yeah.
Okay, great.
Yeah.
Thank you.
Thank you.
Dr. Singh, what do you say about any role of TPA in these cases? Would you use them, or do you recommend?
Actually, I have never used it for suprachoroidal hemorrhage. I used it for the subretinal, hemorrhage associated with AMD or things like that, to try before the surgery, but not for suprachoroidals.
Thank you.
Thank you.
Thank you.